right, hello everyone. My name is Dr. Lauren Kuhn Nuth, and I want to talk to you today about predictable instrumentation in endodontics. So I myself am an endodontist. I went to dental school at Harvard, and as you can tell, I am a younger clinician. I finished dental school a little over 6 years ago, and then I finished my residency 4 years ago. And in that amount of time, there's a lot of learning that takes place. And this is true for all of us, whether you're an endodontist, whether you are a general dentist and you're getting more into endo in your practice, whatever it is that you do, those first few years can involve a lot of growing pains. And then you'll find that the more you're exposed and the more questions you ask and the ways you try to improve, the more that you can hit your stride. So I'd say I hit my stride a couple years ago, and I have made every mistake in the books. So I would like to share with you my practice inspiration, because I know I've been inspired by many clinicians, and there's just a lot to learn about endo. So let's go ahead and get going. So today I want to talk about failure points in endodontic instrumentation. We know that there are many of them. I also want to consider different endodontic file motions. How does the file move? And how can that affect the efficiency and safety of instrumentation? And then finally, I want to talk about how an integrated apex locator, where the apex locator is combined with the endodontic motor so they're working simultaneously, can help to improve length control and also our patient outcomes. I also have a disclosure to provide. I am a key opinion leader for Comet USA, who has also provided me with an honorarium for this presentation. However, all the opinions I'm expressing are mine, and I'm sharing what my experience has been. I'd also like you to know that I am a part-time educator at the University of Minnesota School of Dentistry for the last 3.5 years, and part of what I'm sharing is also related to what I've seen in the clinics. So for those of you who are familiar with the Swiss cheese model of accident prevention, you know that there are many safety nets or layers of Swiss cheese that prevent bad things from happening. This is true with airplanes and making sure that there's not a crash. This is true for cybersecurity, making sure you have the appropriate firewalls in place and ad blockers, whatever it is that you need to keep yourself safe. So you have all these layers. So you imagine an accident as being something small, but it has to make its way through all these layers, all these safety nets or layers of Swiss cheese. Now, when you're practicing dentistry and specifically endodontics, you'll find that there are a lot of things that can go wrong. And when that happens, all these little problems can kind of scoot their way through these layers of Swiss cheese. And usually you as the provider, you are the final layer. So you are the last one who can catch something before it goes wrong. For example, treating the incorrect tooth or having an incorrect working length, maybe over-instrumenting, maybe working on a tooth that's not quite numb enough or having an inappropriate diagnosis. You are the final layer of Swiss cheese. And that's important for our patient's safety and for the efficiency of your practice and overall your reputation as well. So we use our critical thinking, empathy, our tactile sensation, that helps us to prevent issues such as instrument separation, sounds that we listen for, vision, things that we're seeing while we're practicing, and then you notice patterns throughout your years of practicing, and you even notice the body language of the patient. So with all of this technology at our fingertips, I've often asked myself, why do I have to always be the last layer of Swiss cheese? Why am I always the one catching everything? Why do I always have to be the one feeling and sensing and trying to figure out every little thing? It's almost like you're on edge the entire procedure because you know something could happen and go wrong. I really wish that there was a way that some type of an instrumentation system or some piece of technology could tell me when I need to stop and to help me, like be my partner, be another layer of Swiss cheese to help be a safety net and prevent bad things from happening. And to kind of tell me, when something is unsafe and there's some danger ahead. So there are pieces of technology that we're going to get to that I want to talk about that have really inspired me in practice and helped me practice more efficiently and safely. And they really align with my goals as an endodontist. And according to the American Association of Endodontists, There are four main goals. So three of them were listed way back in 2002 and another was listed in 2005. But the two that I would like to focus on today are that our goals are to remove irritants from the root canal system. So that typically is necrotic debris, infected dentin, and of course bacteria. And number two is to fill or obturate, in other words, the cleaned and shaped root canal system. So we need to be able to efficiently and safely clean and shape the full system, and then we need to be able to fill it to prevent future infection. So that's what I want to talk about today. So those irritants, again, we know that our main culprit is bacteria. We know that in the absence of bacteria, you can have all sorts of crazy things go on. You can have pulp exposures, you can have trauma, and you don't end up with infection. The reason you don't end up with infection is because there's no bacteria. So if you're in a sterile environment, no problem. But our mouths, as we know, are like little petri dishes. And bacteria are everywhere, including in the root canal system and in those fins, isthmuses, and then at the very tip of the root, so right in the apical third, that is the most key region for cleaning and shaping. Many providers believe, and I see this all the time at the dental school, they believe that the coronal and middle thirds are the most critical because they're larger, of course. So if you get those clean, then you're removing the most bacteria. But the problem is the tip of the root, which is much smaller. The tip of the root is what is in contact with the apical periodontium. That's where everything leaks out, right? It's like a garbage can with a hole in it. Everything is leaking out the bottom. You imagine that even though it's smaller down there, it might seem less important. It's actually critically important that we're able to clean down there, maintain patency and not block ourselves out, and that we're able to then fill down there as well. So even though that might seem like the smallest area, it's actually the most critical area. Now, the issue with that, of course, is that it's the furthest from where you are. It's all the way at the tip of the working length. It's all the way down there. So what can happen? A lot along the way. So we need to remove these microbes. We know that oftentimes they're highly organized in biofilms. So we can't just get down there with a file one time and call it good. We need to be able to irrigate really well in addition to that. And if we don't do that, that can lead to failure of the root canal. It can be a beautiful x-ray, but root canals that are beautiful don't always work because just because it's beautiful on the x-ray doesn't mean it's clean. So how do we clean and how do we shape? So instrumentation, mechanically, so hand files and motorized rotary files, and then of course our irrigation, which is a chemomechanical kind of cleaning, usually with sodium hypochlorite, which sort of effervesces and bubbles to get rid of bacteria and to lift organic debris up and out of the root canal system so it can be suctioned out. Those are some of our main ways of cleaning. And we know that even with our instrumentation, so many of us are very focused on hand filing and rotary filing, that is not going to get everything clean. The instruments cannot possibly touch all the walls of the root canal system, at least with the current technology that's available. So what can we do? We can certainly try our best, but we know that about 35% of the root canal system will be untouched. So we're not going to be able to mechanically scrape and clean all of the walls, but we do need to keep everything open so that we can have irrigation flow down and get into those little nooks and crannies and isthmuses. So what are some points of failure in endodontic instrumentation? Well, obviously, if you fill the root canal more than 2 millimeters from the apex, so an underfill, or if you fill long, overfilling, those are some big problems. So underfilling usually represents the fact that you probably didn't get it clean all the way to the tip, and again, that apical portion is the most critical, even though it's the smallest. And then overfilling, gutta percha, and some sealers, not all sealers, can be cytotoxic. So that's another issue there. Perforations obviously are an issue and they become contaminated with bacteria. And then instrument separation, which is everyone's nightmare. Instrument separation is a problem not because the instrument is metal and now you've got metal in your tooth. That's not the issue. The issue is that wherever the instrument separated, now you're going to have almost an impossible time cleaning around it. And if you can't clean around it, you also probably can't fill around it. So now you end up with this area where bacteria can flourish and go unchecked. So here's a few images. You can see that there's an image of a separated instrument here in that first and second pictures, and thankfully this clinician was able to get around that. So something like that, the prognosis would be unchanged, even if the instrument remained in there. There's nothing wrong with the instrument being in there itself. It's the fact that you might not be able to get around it to clean and then to obturate. So it doesn't necessarily mean failure, but there is a higher incidence of root canal failure when there's a separated instrument. Again, it's not because of the instrument, it's because the instrument blocks you from doing these other things. So you can't fulfill your other goals. You know, A is blocked off, so now you can't get to B and C. And it's interesting because many of us are using rotary files. There are actually studies that show, and this is that bottom part of the slide, that a clockwise rotation, so spinning to the right, now I may be mirror imaged right now because I'm on a video, but you imagine spinning to the right, a clockwise rotation, like the hands on a clock, that is going to have a greater chance of file separation than a counterclockwise or a left spinning rotation. So it seems like it would be advantageous if we could switch our rotary instrumentations to more of a left cutting or a counterclockwise rotation. In addition, a lot of times the reasons that instruments separate is because of torsion. Basically, a part of the file is bound somewhere, so it's like it's stuck, it's pinched, and then you keep going and you keep twisting and it just snaps off. So that's a torsional failure. Whereas a cyclic failure is kind of like if you bend a coat hanger many times, bend, 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 bend. It's not bound anywhere per se. It's not like you're twisting it to try to break it. It's just that it can't handle it anymore. And there's curves in root canals, even if you don't realize they're there. They're in the buccal and lingual dimensions. They're in different dimensions than maybe what you can perceive when you're looking at the radiographs. So yes, they can fracture due to torsion. They're bound. That's why when you push a file, if you feel too much resistance, you should stop. You should not continue pushing. Like, ask me how I know. If that happens, you will most likely separate a file. So you have to be the layer of Swiss cheese on that. There is some technology that can help us with it, but again, technology can't do everything for us in our jobs. And then again, that cyclic fatigue failure is also an issue. The interesting thing about this is that nickel titanium instruments, which are very flexible and which is what most of us are using, they tend to fracture within their elastic limits. So it's not like we're asking them to do something crazy. We're not trying to bend it, 180 degrees. We're not necessarily doing that and then, oh, it breaks, surprise. No, we're actually using them within the limit that we think they can work in. It's just that we went a little bit too long. So if you hold a file at length for too long, it's very risky. Or if you use the file too long. That's another reason why we recommend single-use instrumentation. So you see that 2 with the cross through it. That means only use it one time. That can help because you can't always tell when a file is going to separate. So it seems logical that we have to assume that any file that's worked too hard is ready to break. So using a file once is a good idea. Having something that's left cutting, again, counterclockwise, less likely to fracture. Heat treated, it's flexible. And then a variably tapered core is also a good idea. So a simple file design that doesn't have a variably tapered core may not be able to help pull debris upward. So then the issues with that, and you can ask the manufacturers that you work with, if there's not enough space for debris to be lifted and the core of the file is taking up all the space, that's basically the backbone of it, then what you end up having is everything gets gunked up and all the flutes in the file get gunked up. Now what happens? Now the file starts to engage in places that it was never intended to engage. And again, it's more likely to separate. So it's important to ask about that when you're looking at file systems to purchase. So we know that our reflexes as providers help increase the safety of instrumentation, but there are also ways that we can have technology help us. So we know that safety also equals efficiency and predictability. So when things are safe, usually you feel good about how long it's going to take you to do the procedure, how predictable it'll be, will it actually heal? You need to look when you're buying files. This file down in the bottom right is from Comet. It's a Crocodile Q file. But you should look at studies about how they handle cyclic fatigue and torsional fatigue. How do these files do in comparison to other files? Are they flexible? Are they heat treated? And what's the chip space like? Is there a variably tapered core? Do they rotate in a counterclockwise motion, or is it a clockwise motion? And is there some kind of safeguard in the technology that if you encounter too much stress, that it will actually back you out or stop you? So ideally, we would have an integration between the apex locator, the electronic apex locator, and the endodontic motor. Now we're starting to see this integrated in many new offerings from various dental companies. And this is really helpful because you can know where the file is in real time, and there are often settings that can help you to stop once your length is reached. So you don't always have to be the final layer of Swiss cheese, although you should always be on guard and be looking. But the motor can then be your partner and help you to determine if you're going to be short or long in your instrumentation. Ideally, this would help you to customize your preparation length. If you have a vital case, you may choose to prepare a little bit further from the apex because you know that there's not really as much of a bacterial problem. Whereas in a necrotic case, you might choose to prepare much closer toward the apex. So ideally, something like this would be customizable. And that can also help you prevent chip compaction. So those infected dentinal chips can help you prevent the packing of that near the apex because these systems will then start to move you away from the apex if you're starting to pack and there's too much force. And an insulated handpiece can help prevent interferences. So these are things that you should look for if you're thinking about buying a new system. But what I'm wondering too is, okay, this is all fine and dandy, and it helps me as a clinician, but oftentimes our patients, what they know is how long did the procedure take? Was the provider nice to me? What was my experience like at the office as well with the staff? And then how much pain did I have afterward, right? Those are some of their main things that they're looking for. So can this integration of the endodontic motor and apex locator reduce pain? Well, we have to think about what causes pain after a root canal treatment. There can be many factors. They can be mechanical, such as instrumenting long. They could be chemical, such as extrusion of sodium hypochlorite out the apex. They could be microbial. You're packing and pushing debris out the apex and you're not cleaning your file out. Maybe there's not enough chip space because you don't have a variably tapered core. Everything is just being shoved out the end of the root. There are many reasons that you could have an acute inflammation after treatment. So we should be aware of all of those and try to prevent them. But one of the most common factors, and the one that's most relevant to today's discussion, is postoperative pain that's related to an incorrect working length or loss of working length during the procedure. In fact, we know that working lengths tend to shorten. So if you tend to get a working length right at the beginning of your appointment, maybe with a 10 or a 15 file, whatever that length is, you imagine the canal almost, let's say that the canal is shaped like a banana or like a crescent moon. Okay, that's fine. You're measuring a point to point around a curve. And so you have your length, maybe it's 21 millimeters, and so you do all of your instrumentation to that. As you keep instrumenting, that curve will start to straighten out because you're always going to be hugging that inner wall, that smaller point, kind of like running on the inside of a racetrack. You're always going to be trying to, your file wants to cut the corner. So that working length that used to be 21 millimeters at the very beginning of your appointment now is probably going to be more like 20 and a half, depending on what your curvature is like. So it's going to get a little shorter. So if you're not integrating your apex locator and checking the length while you're working, it's very possible that you could over-instrument. And again, when you over-instrument, you're more likely to extrude sodium hypochlorite or debris out the apex. And then it's mechanically traumatizing too. You're essentially augering out some of those periodontal ligament fibers at the apex. So again, if you integrate an apex locator with your endodontic motor, there are studies that show that it can actually decrease postoperative analgesic intake and decrease postoperative pain. There's another study that shows the same thing. There are different file and apex locator systems that you can use. So again, I'm using the EndoPilot from Comet USA. that's helping me with this, but there are other files on the market and other instrument systems on the market as well that you can check out. And like I said, if you want to do a little DIY, you can use your endodontic motor and then the lip clip from your electronic apex locator to put them together. If you imagine that you have a 21 millimeter working length, you're probably going to want to use a 25 millimeter file then, rotary file, so that you'll have space for that clip to go on there, so that the file clip or file holder can hold right on there while you're working and that you're able to use them simultaneously. That might not work in every case, especially if there is some metal in the restoration, like a PFM crown or existing amalgam. In those cases, I definitely recommend, especially with amalgam, taking all of it out before you get started. That'll eliminate that as an issue. So then you can get some real-time measurements. But if you're going through a PFM crown and you're planning to maintain it, it doesn't need to be replaced. You might have to alter what you're doing a little bit, or you may have to just pause and take measurements at individual times, because if you touch the metal, obviously you're going to get an incorrect reading. So what should I look for if I'm buying one of these systems? What is the future of endodontic instrumentation? From my perspective, I think it's the apex locator where you can use it manually, but it can also be connected to the motorized handpiece. Something like that that's customizable makes a big difference. Ideally, also, we could change our file data. So if we're treating and we want to change the speed at which a file is moving, or the type of motion, do we want to switch it from a rotary to a reciprocating? How do we want the file to move? We should be able to change that as well to increase safety. And ideally, we would also have the ability to set something on our motor that makes us stop when we get to the apex. So this is an image that I have encountered before, is I'm able to change my apex setting. So you can either change it to not stop at all, or you can make it stop for 1 second, and that kind of gets my attention. Oh, I'm long, or something is different here. And so it helps you, again, it's one more layer of Swiss cheese, one more layer of safety net, so that you don't have those incorrect working lengths. Changing the speed, changing the torque, changing the type of motion, all of these things are beneficial in endodontics, and I think that they're going to become very common as we look at the future of our technology. But if we have the ability to change everything, we also need to know when we've changed it. We can't just live in ignorance and think, I changed everything from the manufacturer's recommendations. What does the manufacturer know, right? Maybe, but it's good to bring attention and have a reminder when you've deviated from the manufacturer's recommendation. So I would say that if you're buying a system that allows you to make changes to the file data, that it would have some kind of a reminder, like this little red exclamation point. There are other ways of doing this as well, other little reminders that you've changed it, but just something that's there so that you know that you have changed it and you have deviated from the manufacturer's recommendation. So you can decide, do I want to continue changing it, or do I want to go with the standard that the manufacturer recommends? So that is the end of my presentation. I hope that you all will consider how technology can help you to be more efficient and have predictable endodontic treatment and instrumentation. And I encourage you, when you're looking for new endodontic motors, when you're looking for new files, I encourage you to ask questions. Ask the manufacturers, ask the reps what the features are, because I think as we move into the future, we're going to see a lot of changes that are going to make our files and our motor systems much more efficient and safe for our patients.